Adverse effects of transfusion. Blood transfusions, while often life-saving, carry the risk of adverse effects. These reactions can be classified based on their timing and underlying mechanisms. General overview. Acute or immediate transfusion reactions occur within the first 24 hours following a transfusion. These include a range of complications such as hemolysis, destruction of red blood cells, transfusion-related sepsis, infection introduced through transfusion. TRALI, transfusion-related acute lung injury. Allergic reactions. TACO, transfusion-associated circulatory overload, and FNHTR, febrile non-hemolytic transfusion reaction. Among these, the three most common causes of transfusion-related mortality are TRALI, hemolytic transfusion reactions, and TACO. Intravascular hemolytic transfusion reaction. Acute. This reaction occurs during the transfusion when transfused red blood cells interact with antibodies in the recipient's circulation. It is most often caused by clerical errors, particularly involving the ABO blood group system. The most common symptom is fever. Other physiological signs include hemoglobinemia, free hemoglobin in the blood, hemoglobinuria, hemoglobin in the urine, hyperbilirubinemia, elevated bilirubin levels. These can progress to kidney failure and even death if not promptly recognized and treated. Extravascular hemolytic transfusion reaction. Delayed. This type of reaction typically occurs after the transfusion has been completed, often hours to days later. It is usually the result of an anamnestic immune response to clinically significant alloantibodies, such as those in the Rh, KEL, KID, and Duffy blood group systems. A delayed hemolytic reaction is often suspected when there is no rise or a drop in hemoglobin levels following transfusion. A positive direct antiglobulin test, DAT, is a hallmark of this reaction, which is frequently associated with KID antibodies. Transfusion-related acute lung injury, TRALI. TRALI is a life-threatening condition characterized by acute respiratory insufficiency and bilateral pulmonary edema visible on chest X-ray without evidence of cardiac failure. Symptoms include chills, fever, hypotension, low blood pressure. It may also be accompanied by transient neutropenia or leukopenia. TRALI is typically caused by antibodies in the donor plasma that react with neutrophils or HLA antigens in the recipient. In some cases, it may be caused by antibodies in the recipient's plasma. To reduce the risk of TRALI, whole blood or plasma from female donors should only be used if the donor has never been pregnant or has been tested negative for HLA antibodies. Transfusion-associated circulatory overload. TACO is characterized by pulmonary edema accompanied by hypertension, resulting from volume overload. This condition is most likely to occur in infants and older adults over the age of 70, as well as in individuals who receive large volumes of fluid or even modest volumes administered at a high flow rate. Febrile non-hemolytic reaction, FNH. This reaction is marked by a rise in body temperature of approximately 1 degree Celsius during or shortly after transfusion. It typically results from the presence of preformed leukocyte antibodies in the recipient that react with lymphocytes, granulocytes, or platelets in the transfused blood, the infusion of cytokines that have accumulated in the donor blood bag during storage. To prevent this reaction, leukocyte-reduced blood components are used. Pre-storage leukoreduction is particularly effective in preventing the buildup of cytokines. Allergic reactions. Allergic reactions occur when the recipient has preformed IgE antibodies that react with soluble plasma proteins in the donor blood. Mild allergic reactions, such as urticaria, hives, accompanied by itching, can be managed by administering antihistamines and continuing the transfusion. Severe allergic reactions, including anaphylaxis, involve systemic symptoms such as hypotension, shock, and, in rare cases, death. A classic example is when an IgA-deficient patient has anti-IgA antibodies that react with IgA in the donor plasma. In such cases, Washed red blood cells or plasma components from IgA-deficient donors should be used. Types of transfusion reactions and their causes. Hemolytic reaction, caused by antibodies against red cell antigens. Febrile reaction, caused by antibodies against white cell antigens. Urticarial reaction, caused by antibodies against soluble antigens in donor plasma. Anaphylactic reaction, caused by anti-IgA antibodies in the recipient reacting with IgA or other plasma proteins. Transfusion-related acute lung injury, TRALI, caused by donor antibodies directed against the recipient's HLA or white blood cell antigens. Important considerations. A positive hemolysis finding with a negative direct antiglobulin test, DAT, may indicate a transfusion reaction. Special attention should be given to patients in sickle cell crisis. Reactions may also occur if the patient has received an incompatible non-ABO blood component. In some cases, all red blood cells may be hemolyzed, complicating diagnosis and management. Transfusion reaction. Workup. When a hemolytic transfusion reaction is suspected, a systematic approach must be followed to identify the cause and ensure patient safety. The first step is a clerical check. This is crucial because the majority of hemolytic transfusion reactions occur due to administration of blood to the wrong patient. Verifying patient identity, blood unit labels, and documentation can often reveal such errors. Next, a visual inspection for hemolysis should be performed. This involves comparing the post-transfusion sample with the pre-transfusion sample to detect any signs of red blood cell destruction. Following this, a direct antiglobulin test, DAT, is conducted. However, it is important to note that the DAT may return a negative result if all incompatible red blood cells have already been destroyed. This is particularly common with ABO antibodies, which can rapidly activate the complement system, leading to swift and complete lysis of red blood cells. An ABO blood group test should also be performed on the post-transfusion sample to confirm compatibility. If any errors are detected in the steps above, additional testing is required. This includes performing an antibody screen on both pre-transfusion and post-transfusion samples, repeating the cross-match on both sets of samples to identify any discrepancies or incompatibilities,